This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Good afternoon, everyone. Just excuse the time it took me to get up those stairs. I completed my first marathon yesterday, and quite fittingly I had, thanks, first and last, but I had many thoughts throughout the run about the ability of those around me and their ability to respond to a deteriorating patient should they need to respond to me. Anyway, enough of that. My name's Steph Barwick and this is my colleague Robin Dickey, and we're from Mater Health Services. Just a little snapshot of the organisation we're from. Mater Health Services is a unique not-for-profit health service that provides quality health care to both public and private patients. We're situated in South Brisbane but have campuses in Redlands and soon to be Mater Springfield. Mater Health Services has a long and proud history of education and training, and as a department, Mater Education supports simulation training across the organisation through the supply and mentorship of simulation training. Today, Robin and I are really quite proud and excited to be able to present our project to you. This is a project that we have cared for since inception and have watched grow and develop into something much bigger than we ever expected. The initial concept of this program came after conducting an informal audit. The need for an in situ or point of care program, simulation program following formal resuscitation training alongside an e-learning package for a deteriorating patient was identified. A small pilot study of in situ simulation focusing on CPR skills conducted in the latter parts of 2014 received extremely positive feedback and exposure to a really large cohort of staff across all disciplines. Feedback from clinicians at the time indicated that they didn't feel annual competencies in resuscitation training was enough to support the retention of their skill, which is an issue that is highlighted in current literature. Clinicians also reported feelings surrounding a lack of confidence and a lack of practice in responding to and managing a deteriorating patient. We looked across our organisation and recognised that parts of it were doing really great things with simulation in the clinical space, and in particular the Mater Mothers had already an in situ program around maternity emergency management in the birth suite. We saw the gap was in the Mater Private and the Mater Adults, and so the pop-up SIM program was born. A significant risk that the Mater Health Services faced at the end of 2014 was with the movement of the majority of our paediatric services to Lady Salento's Children's Hospital. There was a large gap in personnel trained in responding to paediatric emergencies. While the organisations at the time put strategies in place to ensure all clinicians caring for paediatric patients on our remaining private ward and as a part of a medical emergency team had access to appropriate annual training in paediatric life support, there was a risk that this newly acquired knowledge may not be maintained in the long term. It posed significant concern for our organisation and the wider community, especially given that we still had a private paediatric service. The other compounding factor was that the old Mater Children's Hospital was being repurposed for a cohort of patients from paediatrics to adolescents to young adults to complex neurosurgical patients. So we knew that a significant amount of training needed to be invested into the response of a deteriorating patient in a complex service from a team who has always been predominantly adult specialists. We felt simulation would address this problem and really thought that the pop-up simulation program was the way to go. At the same time, we had the opportunity to apply for some grant funding through Mater Foundation. We applied and were successful, and this funding supported the program with the initial financial assistance to purchase some equipment and employ a project coordinator. Mater Education gave in-kind assistance through the support of a simulation coordinator and simulation educator. At this time, conversations about this program and the engagement with key stakeholders began. Interest grew, And once grant funding was awarded, we had the support of the hospital executive team, the Clinical Quality and Safety Unit, and the Resuscitation Committee. Medical and nursing directors were also extremely supported and communicated with their teams the expectation of involvement in the program. Liaison occurred with each ward as well and department to find out exactly what types of simulations were needed in their local area. From looking at other successful similar programs, it was decided that we needed a specific day and time each week that we would run a simulation to get it embedded in culture. Initially, we trialled 2:30 in the afternoon, but this really did not work. We found that no one wanted to end or start their day with a simulation. We then trialled 10:30 a.m. and had support from the clinical areas. After a few trials with days, it was decided that Wednesday at 10:30 a.m. was the best day, and this has worked really well on the public side of the road. The MARTA private has been a little harder. Initially, after discussions with the nursing director, we had agreed upon Mondays at 10:30, but after trialling this set day in the MARTA private hospital, we realised we needed to be a bit more flexible. Mondays at 10:30 was difficult to engage a response from the MET or Code Blue team, as it was often the handover day in ICU, so it really impacted on their clinical work. It was also hard with the clinical educators, as not many of them worked on a Monday. We knew that for sustainability, we needed to ensure that the local educators were engaged in the planning and running of the simulations. Since our first simulation, we have ran 20 simulations across 17 different clinical areas, and it has seen 211 clinicians participate.
So I want to talk to you about the evaluation of the project. So we went into this project thinking about two main things, and they were to see if teamwork improved over time by running this point of care simulation program, and to see what the minimum amount of training was to sustain that learning and training that people had had in their base ALS or PLS programs. We quickly realised that because of the dynamic nature of MET and Code Blue teams, that our original evaluation strategy was not going to work, and that we quickly expanded into other evaluation areas. So the two things listed there, we wanted to determine if recognition of deteriorating patient simulations improved teamwork over time. So we weren't able to see that because we have rotating registrars and residents and everything changes so dynamically. And we wanted to see if that simulations gave adequate support and opportunities for staff to be engaged in that team training. So we used the TEAM tool, so this is the Team Emergency Assessment Management tool, which was developed by Simon Cooper and his team from Monash in 2010. So it's a 12-point scale, so it has 2 items that look at leadership, 7 that look at teamwork, and 2 that look at task management. There's also an opportunity for participants to use a global score. It's a very quick and feasible tool, so that's why we went for that one. So to ensure that we had buy-in from the group, faculty were the ones who actually implemented this tool to begin with. So 2 faculty would rate the same simulation to see if we had good inter-rater reliability within the team. And following this pilot period, we got our participants to fill in the tool to reflect on their own performance within the point of care simulations. So we had 211 people participate, and we had a number of team tools completed. So 22 faculty, 34 doctors, 81 nurses from registered nurses down to patient care assistants and AINs and others. So we had orderlies, our wardies are part of our MET team, so we decided we would look at their teamwork as well, some administration staff and students, and so there was a couple of medical students and diploma of nursing students as part of that. We also wanted to look at, for those people who don't attend advanced life support training, so I'm not sure what it's like in your organisations, but our organisation only funds critical care nurses to attend advanced life support courses, so people in PACUs, EDs and ICUs. So we wanted to see whether that changes people's teamwork behaviours. So you can see that most medical officers have attended some sort of ALS or PLS program, and that in nursing, you've only got 23 out of the 81 people who have attended a course. And you can see that some of the students attended ALS as well, so that's good to see. From an overall view, we looked at, this is a combined score of faculty and of participants. So this is looking at comparison of means against means. So the scale was from 0 to 4, 0 reflecting never or hardly ever seeing those teamwork or leadership or task management behaviours, and 4 reflecting always. Excuse me. So you can see that across the board there's fairly median scores. You can see leadership at 2.5, teamwork at 3 and task management at 3. So they're pretty, everyone thinks they're doing a reasonable job. Interestingly though, the scores for leadership didn't always, and I suppose teamwork and task management, didn't reflect that overall score. So for example, people who related leadership or rated leadership poorly, so they gave themselves a 0 or a 1 for leadership, often their overall score would be a 9 or a 10. So I'm not sure about the psychometrics of that instrument, and perhaps that's some feedback for the authors to see some more testing may be required. We divided them up into key groups across medicine, nursing, other and faculty. And I suppose there's a couple of key points from this data. Faculty have received extensive training on human factors and crisis resource management. So I think we, as faculty, were probably a little bit harsh on our expectations of what leadership, teamwork and task management would look like. Doctors were usually the leaders, and often would not feel comfortable giving feedback to each other on their leadership or task management ability. So even though we asked the team to fill out the teamwork tool before the debriefing, we're not sure if these adequately reflect insight of what that leadership skill was. And also nursing, I think, because they weren't often the leader, were pretty harsh on the leadership as well. So I think as nurses, and I'm a nurse, so I speak for myself, we can often be highly judgmental in the moment of what leadership should be. Overall, so the N score, again, medicine and other scores were quite high, so they perceived their overall teamwork to be quite good in comparison to nursing and faculty. So I think that reflects the previous scores. We asked participants to rate whether they found the simulation program helpful, so whether it was helpful in their role. And the scale was from 0 being not helpful at all to 5 being extremely helpful. And you can see that nursing and medical staff found the simulation program helpful pretty much the same, on about a 4 out of 5. But interestingly, when you drill down into the individual disciplines or specialties of particularly medical staff, the ICU people, the ICU doctors, found the simulations not very helpful at all. So there's 2 ways that you can take this data. Either the simulations weren't stimulating enough for them, or they didn't see that their role was actually about mentorship of the team and displaying those leadership qualities so that others can perform in the future. So that's something that we have realised as part of the education team, that we haven't set that up adequately to say to the ICU senior registrars that even though the simulations might not be challenging, that you're actually demonstrating leadership teams and that's part of your mentoring role.
Lessons learnt. So we have learnt many, many lessons during the evolution of this program. We had initially planned for 40 simulations across 16 different clinical areas. We certainly covered many clinical areas, but found that due to such a dynamic health environment and certainly lots of workforce changes, it was difficult to reach the numbers that we had first anticipated and overall training saturation. It was quite time and resource intensive. And a challenge also lied in ensuring participants' psychological safety in the simulation. Due to the nature of the program, we had no way of establishing this in a formal pre-brief, but endeavoured to do it prior to the debrief. And it's a strategy that we have certainly seen work. The time of simulations and levels of staffing often made it difficult But due to our earlier engagement of key stakeholders, we had the support of executive to run the simulations no matter what. Patient safety, however, was always at the forefront of our minds. So each simulation we made a decision whether or not we should go ahead or shouldn't go ahead, depending on what the clinical activity was. The benefits of this program has really been in the things that we never intended to measure. We started off, what started off as a fairly informal process that really saw Robert and I saying what we thought should be happening, has actually ended up giving people, and the right people, real tangible outcomes. This has in turn led to the establishment of a formal feedback process of outcomes of each simulation that gets fed back to relevant committees, with lots of areas within the organisation actually seeing value in what we do and adopting it and wanting to replicate it. The activation of clinicians through these simulations in their own clinical environment has generated extremely robust conversations in the debrief, and it really amazed us the level of conversation that the clinicians were able to get to in the debrief. It was certainly valuable for the organisation, particularly around process issues and teamwork issues that had been identified. It was also very interesting to see how the program facilitated the establishment of clinical networks outside of formal committees. And we often saw clinicians from different departments brainstorming almost at a service improvement level post a simulation when they're at a heightened level of activation and potentially more motivated to implement change, or at the very least identify where the change was needed. Future directions. So as mentioned earlier, the evolution of this program has been amazing. Not only is it becoming a part of organisational culture and will continue to be a major part of our deteriorating patient training, but we are now regularly asked to process test recognition of the deteriorating patient scenarios in the opening of new services. We aim to include opportunistic refreshers for those needing basic life support training, and we use mannequin feedback to benchmark effectiveness against international benchmarks. Our biggest goal is to be able to evaluate real code and Met team performance using the team tool to establish whether or not we have actually made an improvement in behaviour and ultimately patient outcome. Acknowledgements just to the rest of our sim team. We couldn't have done it without them. Through our references.